In this video, I'm going to walk you step by step through a complete diagnostic flowchart so you can figure out the most likely source of your back, butt, and sciatica symptoms without needing an X-ray or an MRI. In case you're wondering who I am, my name is Dr. Charlie Johnson. I'm a physical therapist, and my knowledge and experience places me in the top 0.5% of PTs worldwide. So let's dive into it. If you're watching this video, I'm going to assume that you have back, butt, and sciatica pain, or pain, numbness, and tingling symptoms that go in the back, into the butt, and below the level of the knee, oftentimes even into the foot. If you have both sided symptoms, we will also cover that so you don't feel left out. All right. Now, there can be many causes of this. Here's how we're going to work through this. So we're first going to rule out big, ugly, scary things: cancers, fractures, infections, PAD or peripheral arterial disease, blood supply problems that cause you to feel symptoms in your legs. We will talk about disc herniations and other types of disc issues, facet joint, degenerative joint, or arthritic conditions, lumbar spinal stenosis, whereby there's narrowing of the spaces where the nerves travel, usually due to degeneration. Sciatica has a black check mark, not a green check mark, because technically it's not really a diagnosis, it's a symptom of one of these other issues, which is irritating the nerve and causing you to feel sciatica symptoms, pain, numbness, tingling going down the leg. Also, a commonly overlooked cause of back, butt, sciatica pain. Even if it feels like there's damage inside the body, sometimes there is not. Your central nervous system might become a bit sensitized, cause you to feel very real physical symptoms. It's not in your head, it's not made up, but it can mimic, say, sciatica or stenosis or a disc problem. I'll show you exactly how you can determine if your central nervous system is driving your symptoms versus something else in the body. I'll tell you right off the bat, your problem is not due to a myofascial issue, a muscle or fascia problem. It's not due to Piriformis Syndrome, and it's not due to an SI joint issue. If your symptoms are in this area, I'll explain to you very clearly why. So right off the bat, there's two things which can cause pain: your body, whereby you're experiencing pain due to damage of one of the structures in your body, a disc, a joint, something like that, or your brain can make a bit of a mistake and cause you to experience physical symptoms, but you're not actually damaged. We'll talk about that at the end of the video. Let's talk about the body first. Let's roll out big, ugly, scary things. So first things first, cancer. Not very common. About 6 out of 1,000 people will have cancer as the cause of their back, butt, sciatica issue. You can see my source here as to where I get this cluster of findings that we use to screen for cancer. So this is what you want to work through. Ask yourself, are you greater than 50 years old? Do you have a previous history of cancer? It's italicized there because a previous history of cancer is the biggest predictor that cancer is the cause of your back, butt, or sciatica pain. Do you experience unexplained weight loss? You're losing weight, but you're not really trying. And have you not responded to natural treatment? Failure to respond to natural treatment, say PT, chiro, something like that. And this cluster is useful because cancer-causing your symptoms can be ruled out with 100% certainty if you, the person in pain, is less than 50, doesn't have a previous history of cancer, is not experiencing unexplained weight loss, and is responding to natural treatment. Now, if you have a previous history of cancer alone, so you check this box only, and or you check 3 of 4 of these boxes, then we will generally refer out for an X-ray and blood work, ESR, erythrocyte sedimentation rate. We're looking for markers of inflammation in the blood, which might suggest something more sinister, like cancer. Fracture, let's move on. Here's my resource here for this cluster of findings. Are you a female? Are you greater than 70 years old? Have you noted the onset of your back, butt, and sciatica pain following significant physical trauma, maybe a fall and or a car accident or something like that? Do you have a history of taking corticosteroids for some maybe other health condition? If so, we know that corticosteroids over time can weaken your bones, setting you up for increasing your risk of fracture. So if 3 out of 4 of these are present, then we would often refer out to rule out fracture as the cause of your pain. Infection, again, not very common, but you can have disc infections, you can have bone infections, osteomyelitis. So did you note the onset of your symptoms with a fever, just generally feeling unwell, body aches, chills, nausea, fatigue, vomiting, all that stuff? Is there redness in the area of your lower back? Is there tenderness to the even just skin or over the area of the bone in your back, again, associated with all these different things? If so, we may want to consider infection. Blood supply issue. I want to list this here. This is often pertaining to both sided symptoms, but it could be one-sided symptoms as well. So recently I've seen this, and so I wanted to put it on here. Peripheral arterial disease. What you need to know, there again is my resource. So usually both-sided, but can be just one-sided, back, butt, maybe even front of the thighs, sometimes even into the calf, where you feel cramping pain, weakness, heaviness while walking. It's the main complaint, while walking, that is consistent and consistently relieved with rest. It doesn't happen sometimes and not other times. It's consistent. When I get to this distance, when I walk to this mailbox, that's when I get it. And as long as I sit down and I stop my heart from having to work any harder, my symptoms go away. Are you greater than 50 years old? Do you have a history of smoking, high blood pressure, HTN, hypertension, diabetes, high cholesterol, things that would negatively affect the cardiovascular health and or system there? Here's something really important. We'll kind of branch this out so you understand it better. Exertional, not positional. Symptoms are going to be related to how hard your heart works, not the position of your back. Things related to the position of your back might be, say, spinal stenosis. We'll talk about this in a second. Also, if it's an arterial problem, not a mechanical problem with your bones or your joints or the nerves, then you're not going to be able to consistently reproduce this by moving your back in a mechanical way. So if you try these different motions, if we kind of go around the clock, we bend forward to the right, back to the right, straight back, boom, boom, boom. We hit all these things and you're like, you know what? That is not a problem for me. And you know what? I cannot reproduce my symptoms consistently with that. No major issue. Then maybe this. And here's basically what's happening. So you have your heart here and you have your aorta. Your aorta carries blood away, A for artery, away from the heart into the arms, the kidneys, the legs, all of that good stuff. And you can see the blood supply here is perfectly fine on the left. But if we look at this picture on the right, I did my best to kind of cause a little bit of narrowing in this area of, in this case, the aorta or the iliac arteries, in which case you can imagine the blood supply is good and then it kind of gets pinched off. And the blood supply is affected, in this case, to the lower legs, which can cause, when you're trying to use the legs, a lot of heaviness, cramping, just fatigue as you're walking. And let's talk about this. Exertional, not positional. What do I mean here? So a couple things. Take, for example, this scenario. In this scenario, you're walking. Your spine is upright. In this scenario, you are standing. You're no longer walking. Your spine is upright. This position of the spine did not change from scenario A to scenario B. But in this case, while you're walking, your heart is having to work to pump blood to your muscles as they are working while you walk. In this scenario, when you're standing still, the spine position is the same, but your heart doesn't have to work as much because you're not moving. You're stationary. So the difference here is how hard your heart has to work. If stopping to rest and standing reduces your symptoms, then it points to it being a peripheral arterial problem. If stopping to rest and standing does not reduce your symptoms, then this points to it being more of a lumbar spinal stenosis issue. We'll talk more about this in a second. Now, in this scenario, you're walking, your heart is having to work, your spine is upright. As we move on to this side of things, your heart is still having to work. You're walking in this picture, but you're bent forward. So your heart effort does not change, but the position of your spine does. So if bending forward does not reduce your symptoms, then this leads us to peripheral arterial disease. If bending forward, changing the position of your spine, but not changing how hard your heart has to work, reduces your symptoms. This doesn't have anything to do with the heart. It has everything to do with the position of your spine and or compression of the nerves, let's just say in the spine, most likely. This points to it being a lumbar spinal stenosis issue. Here is the article and or the resource that I will use to walk you through this cluster of findings that moves us closer towards believing that it is spinal stenosis. So if you are greater than 48 years old, if you have leg pain that is worse than back pain, if your leg pain, numbness, and tingling increases with standing and walking, but it goes away when you lean on a shopping cart, positive shopping cart sign, walk uphill, sit and or bend forward, then this may be a sign you have spinal stenosis. And oftentimes you will have symptoms more so in both legs than just one leg. And if you have 4 out of 5 of these things checked off, then there's roughly a 76% chance that you have spinal stenosis. Now, if you have both-sided symptoms, and this points towards it being more of a lateral recess, or what we call foraminal stenosis, foramen being the spaces in the spine where the nerves exit, so the holes where the nerves exit, and each of those is kind of closed off due to degeneration or something like that. And you can see that it affects both legs then downstream, below the pinch point. It's possible you could just have central canal spinal stenosis. Maybe the holes where the nerves exit on either side are fine, but it's the central canal due to thickening of the ligaments in the spine or in the canal that is causing you an issue. And again, both-sided symptoms would be the result. Maybe you have a disc herniation, which is causing pressure on either the holes where the nerves exit or maybe even the central canal. So just some things to consider. Believe it or not, a disc herniation can actually cause spinal stenosis as well. Now, if you have one-sided symptoms, you're most likely experiencing lateral recess or foraminal stenosis. Stenosis on one side of the spine where the nerves exit within that foramen or that opening. Now, If your leg pain increases, your numbness or tingling, your symptoms increase with standing and walking, and you've gotten to this point in the flow chart, then chances are it's due to neurogenic claudication, which is associated with spinal stenosis, whereby you get some compression of the very base of the spinal nerve roots, which causes a lack of circulation to those nerves. And then you get this heaviness, this weakness, sometimes even changes in balance, and then numbness and tingling in, again, often both legs, but sometimes one leg. But let's go ahead and let's prove it with a self-movement test, what I call an up-tall test. So what I want you to do is I want you to walk as you normally would, and usually you're slightly tilted forward. As we get a little bit older, we tend to pitch forward as we walk, and we think we're walking upright, but we're not really. So then I want you to push your hips forward, pull your hips underneath your shoulders, and try to walk up as vertically as possible. And what could happen here? Well, a few things. Number one, it could feel better, in which case you don't have lumbar spinal stenosis for sure, because when you stand up taller, you should actually worsen your symptoms and close down the spaces where the nerves travel. If there's no difference between when you are flexed forward slightly and you're walking and when you really try to accentuate the upright posture, then you likely do not have spinal stenosis, because this should make it worse more quickly. And if you say, ouch, that makes my leg symptoms way worse when I stand up tall like this, then this does indicate with a higher degree of certainty that lumbar spinal stenosis, along with all the other associated symptoms, is the most likely cause of what you're dealing with. Now, if moving your spine doesn't really seem to impact your symptoms, it's also very possible that your central nervous system is mimicking lumbar spinal stenosis, but you don't actually have it. Now, again, it doesn't mean it's not real. It just means I've seen this way too many times to pass up the conversation about it. So Pearl was a woman who joined the program with us because she thought she had spinal stenosis. She would literally have to bend forward or squat when she was walking through the store because walking upright made her worse. And so it kind of matched the description, right? She's 59, so she's greater than 48. When she's upright, she gets her symptoms, her pain, numbness, and tingling. When she bends forward, it feels better. Everything kind of sounds like it, but something wasn't adding up. And so we basically went through a process that I'll go through at the end of this video with you of starting to look at all the evidence and all the clues to really diagnose what was happening first before we started treatment. And so what she found is that her symptoms were actually due to a central sensitive nervous system. She felt the pain. It was very real, but her brain was making a bit of a mistake and causing her to feel these funky symptoms. So her brain was very good, as your brain might be as well. And now she's running a marathon. She's resumed playing soccer. She's not taking meds. We've taught her how to become her own best anti-inflammatory and solve the problem. Okay, so now let's talk about some more common things like disc problems, piriformis syndrome, all that fun stuff. So if you have symptoms in this area, I alluded to the fact that you likely do not have a muscle or fascia problem. Regardless of how many times these things get blamed for the cause of pain, they often are not. And that's just because the science and or evidence doesn't support it. Okay, so a lot of times people will say, well, my QL is the problem, or my psoas, my hip flexor muscle is tight, and that's why I hurt. My hamstring is causing me to feel pain, numbness, tingling. My glutes are referring pain down my leg. Well, maybe, but maybe not. So despite what a lot of people have been led to believe, we don't have high quality studies to suggest that muscles are a significant contributor to back pain. And in fact, a lot of evidence now is debunking this myth of trigger points, tender points, or knots in your muscles themselves. It's not that when you push on it, it doesn't feel tender in it. You may actually be able to push on a muscle and feel symptoms down your leg, but is it actually a trigger point or muscle problem, or is it a nerve problem? And that's what we're finding now. A lot of the evidence is suggesting that these trigger points or these tender points in your muscles, the reasons that you can push on a certain area of your muscle and feel symptoms down your leg is not because you have some issue with the muscle or that the muscle is the cause of pain, but instead because you have irritated or sensitized a nerve, a wire in the spine, which plugs into those areas where you feel tender. If you have pain in your back, butt, hip, or leg, and it goes down the leg, below the level of the knee into the foot, chances are if you poke or roll on a ball or a foam roller on your calf muscle, it will feel very tender and it'll feel very tight. But it's only because the wire that supplies function and feeling and sensations to that muscle is irritated. So kind of weird. You irritate the L5 nerve, and now all of a sudden, all the muscles which are supplied by L5 become tender. Isn't that kind of ironic? So you'll feel pain in your butt when you touch it. It'll be tender to the hamstring muscles, the calf, all these different things. So you'll try to pound these things out. You'll try to massage them out. It won't work until you reduce the sensitivity of the nervous system, the root cause of these things. Piriformis syndrome. If you have back problems and or pain around the belt line, which you should if you're watching this video, then you do not have piriformis syndrome, because as you can see here, the piriformis muscle does not refer pain upstream. It can cause pain in the butt, and downstream, maybe even into the foot or the leg if it irritates the sciatic nerve, but it does not cause pain to be felt up in the back. Versus a back problem can cause pain in the back, but then downstream, anywhere downstream, which can make the piriformis area hurt. So a lot of times people think that they have piriformis syndrome, but it's really a back problem causing a pain into the butt. SI joint issues. Is it possible? Maybe, but we will see that people with SI joint issues do not have back pain as defined by pain above the level of the belt line, here along the belt line or up into the lower spine. It's just below, often one side, and most people feel pain only in the butt. And it'll often not go below the level of the knee into the foot. You can see there's some lightly shaded gray areas here for folks who have sort of been confirmed as having SI joint pain via SI joint injections, but it's not very common. So those two things start to rule out SI joint as the most likely issue. So if you have symptoms here, back, butt, below the level of the knee into the foot, what is going on? Well, probably the first most logical thing to do would be a screening test, whereby you test to see, do you have nerve irritation or not? So let's rule that in or rule that out right away. So I want you to go ahead and I want you to perform what I call a straight leg raise test. So go ahead and do this on the painful side for me. So you're going to start, this is the end position, by the way. So start with your leg straight, heel on the ground, pull your toes up and raise your leg up. Perform this on the painful side, and one of two things are going to happen. It's either going to be painful, in which case you likely have sciatica, we call it radicular pain, nerve pain, or it may be referred pain. So it might be pain-free. And if it's pain-free, it tells us that with a high degree of certainty, 95%-ish certainty, you do not have sciatica. You don't have irritation of your nervous system, the L5, the S1, any of those nerve roots that come out of the spine. So let's talk about sciatica. This is the most likely cause of symptoms below the level of the knee. So you have sciatica. What is the cause? Right off the bat, I'll tell you it's most likely not lumbar spinal stenosis, and here's why. So when you're in a seated position, these are the bones, these are the discs, this is the hole, the foramen, and this is the nerve that would exit. All right, so I'm going to kind of put that in like an infographic here that I drew up. So you have L4, L5, S1, these are the bones, and when you're in the seated position, what do you see? What do you notice? That the nerve has a lot of space to travel. The foramen or the holes are kind of gapped or open, in which case there's no pressure on the nerves. Well, lumbar spinal stenosis is a compressive problem, which is why it bothers you when you stand and you walk, but it feels better when you bend forward. So when you're bent forward and you go to stretch the nerve, most people don't feel pain or don't feel problems because you're not pinching the nerve off actively during this test. So most people with lumbar spinal stenosis, while you may have pain, numbness, tingling going all the way down the legs, do not have a positive straight leg raise. It is not painful because the position in which you perform this test is in a bent forward or flexed position, thereby gapping and or taking pressure off the nerve roots while you're doing it. Okay, so if you've got a positive straight leg raise, this starts to reduce the likelihood that is due to lumbar spinal stenosis. But what could be causing it? Here's what I want you to do next. Try that same straight leg raise test, this one that we just did, and I want you to do it on the pain-free side. So we know it's painful on the painful side. Now I want you to do that test on the pain-free side. And we call this a crossed straight leg raise. And it's either going to be pain-free or it's going to be painful. If it is painful, then this is a very diagnostic sign of you having a disc problem. Basically, with 90% or more certainty, we can say you've got a disc problem causing your back, butt, and sciatica pain going all the way down the leg into the foot. Now, if it's pain-free, chances are, because disc problems are the number one cause of sciatica, that you have a disc issue. All right, so that is still the most likely cause, but this just makes it, kind of seals the deal, if you will, makes it very clear that a disc problem is causing your pain. Now you might say, well, what kind of disc herniation? Can we get more specific? And what nerve root level is affected? Absolutely, we can do that with a solid clinical exam. So what kind? Chances are you have a one-sided disc herniation, and here are the other signs associated with it. So kind of check these boxes off to see if it fully makes sense. So are you less than 50 years old? Do you have central or one-sided lower back pain that may shift from side to side? Do you have trouble straightening or standing up after you've been seated for a while? So there you are sitting in the car, sitting at work, and you got to stand up. It feels super stiff and hard to straighten up. Is pain worse in the morning? This is associated often with disc issues because disc pressure is highest first thing in the morning after you've been, off of your feet. Is your pain often worse while sitting, driving, bending, lifting, twisting, or coughing and sneezing? All of these things tend to increase pressure within the disc. It is often, but not always, and we'll talk about a case where this is actually not true, whereby the pain is actually worse while walking or standing. Is your pain better while walking, standing, or lying down? Do you have a roller coaster of back pain, whereby your pain sort of came? Love you. What's up, baby? Sure, that's fine. Do you experience a roller coaster of back pain, whereby your pain went out on you maybe many years ago and then it got better? It went out on you and it got better. But this time, things are different. Now you have pain, numbness, tingling going down your leg, and it's just not getting any better. Oftentimes, it gets worse over time with every time it does go out. Sciatica, number one cause is a disc problem. If you have a right-sided disc herniation, you'll almost always feel symptoms just on the right side, left side, and you might be shifted. If you're shifted, again, this is like a classic telltale sign that you have a disc issue. So if you have a right-sided disc protrusion or herniation, then you're almost always shifted away from the side of pain. If you're shifted towards the side of pain, then oftentimes it makes it harder to correct naturally, but not always. If you have a left-sided disc herniation, you'll often be shifted to the right, away from it. Now, what other kind of disc issues are there? Well, it's possible, depending on how bad your symptoms are and the presentation, you might have a large disc herniation, a large disc protrusion, or a disc extrusion, or even a disc sequestration. And in this case, unloading will feel best, lying down or decompressing. Pain is often better sitting and or recline. Again, unloading, taking a little bit of gravity off the spine. In this case, pain is often worse while walking and standing. Notice how I set up here for a more mild protrusion that pain is often better while walking and standing. Well, if your pain is due to an extrusion or a sequestration or something bigger, a bigger disc issue, then pain will often be worse while standing and walking. And here's what you'll notice. The classic disc exercise will actually make you worse. Back bends, cobras, all that will be very yucky, and you actually will respond very favorably to moving in the forward direction. So you can see here, this is a live MRI of somebody bending backwards, and extension or bending backwards actually increases the size of the disc protrusion. But the same person bends forward and actually reduces the disc protrusion. You can see here that if you have narrowing of the spaces where the nerves travel, spinal stenosis due to a disc problem, then bending backwards can actually further narrow that space and make you feel worse. Bending forward can actually gap the spaces in the spine and make you feel better. You will often have a positive cross straight leg raise because this disc herniation is larger, leading to more issues with the nerve roots. And not all the time, but oftentimes you'll be shifted in the way that you present. All right, so that's disc herniation. But what nerve is affected? If you've got pain, numbness, tingling going down the leg, can we even get more specific? Right off the bat, we know probability-wise the L5 nerve is one of the most common. So roughly 50% chance that it's the fifth nerve in the spine. You've got L4, L5, S1, S2, S3, these different nerves that come off this plexus or bundle of nerves in the spine. And this is what you'll experience. You'll experience symptoms almost always in the back side of the leg, but also the outer side of the knee and in the IT band region, the shin area, and the outer part of the foot, and it'll wrap to the big toe. So you can see I kind of made a picture of that right here. Nerves carry information such as feelings. This is where you'll feel funky feelings, numbness, tingling, altered feeling. And this is where you'll feel loss of strength. So nerves are like highways that carry information such as feeling and movement or strength. And if you compress a nerve here and all the signals are not getting down it, you will notice that you can perform a simple strength test such as walking on your heels. And if you walk on your heels, and you've made it to this point in the flow chart, and you notice that one of your feet kind of flops towards the floor, then you have what we would call foot drop. And that would be indicative of the L5 muscles not working very well because the L5 wire is not functioning and or not healthy at the level of the spine. S1 nerve follows closely behind. About 46% of people have the S1 nerve affected. Slightly different location. You'll see there's almost no front of the leg pain and is all back, butt, hamstring, and calf pain. And then on the foot, it doesn't go to the big toe. It goes to the heel, wraps to the outer two little toes there, and to the bottom of the foot. Slightly different in the way it presents feeling-wise. And because the S1 nerve supplies slightly different muscles at certain points in the body, you will not be able to go up on your toes if the motor nerves, if the strength portion of the nerve is affected. So go ahead and do some heel raises on the pain-free side, see how many you can do. Then go ahead and try it on the painful side or the symptomatic side and see how many you can do there. If you struggle to do a heel raise, usually it's pretty darn clear, then you have an S1 nerve issue. L4, not very common, but can occur, 4%-ish of people, pretty darn rare, but you'll see almost entirely that people feel sciatic-like symptoms on the front of the leg, the front of the shin, the inner ankle bone. Some of the symptoms might be in the back as well. So there's a little bit of overlap. Here's the strength test that you would want to perform. You're going to perform a seated sit to stand because the L4 nerve supplies function to the quadricep muscles, your thigh muscles. So go ahead and perform as many single leg sit to stands as you can. Hold on for balance if you need on the pain-free side. Then go ahead and try to do that same thing on the painful side and see if there's a clear difference. Not like 1 or 2 reps. Like I could do 10 and I could barely do any. Right? That's what we're looking for there, a clear difference. Now, a self-movement test, you saw it, the leg raise will often be yucky for people with sciatica. Well, what's a specific test maybe we could do to tease out with even more certainty what level of nerve is affected? Well, go ahead and perform the belly knee bend test. What I want you to do is I want you to lay on your belly, maybe put like a very small towel roll or pillow underneath your pelvis so you're not arching your back when you do this. And either go ahead and try to do this on your own or have someone take the ankle and try to bend it towards the butt. Take the ankle, try to bend it towards the butt as if you're trying to touch your heel towards your butt. Now go slowly. You can try this on the pain-free side and then try this on the painful side. And here's what you'll notice. If there is a positive straight leg raise, which there is because you're here at this point in the flowchart, and a positive knee bend test, well, then this points to an L4 issue because you have the sciatic nerve, which is made up of the L4, L5, S1, S2, S3, and the femoral nerve in the front of the leg, which is made up of L2, L3, L4. So L4 is the common link. So we know that if they're both positive and or painful, that is an L4 problem because L4 is the only common shared thing between these two maneuvers. Now, if you have a positive straight leg raise test, pulling on these nerve roots, L4, L5, S1, S2, S3, but you have a negative, meaning pain-free belly knee bend test, then this points towards it not being an L4 issue because they should both be painful if it is an L4 issue. Instead, it's an L5, S1 issue, and you could use this flowchart to figure out what level was the issue. Now, here's the deal. Somebody comes to me and says, hey, I've got a loss of strength. I can't walk on my heels, maybe an L5 problem, walk on toes, S1, can't go sit to stand. I've got a loss of feeling. I'm losing bowel or bladder control. Then oftentimes this is when we'll refer out to an orthosurgeon or get an MRI to confirm a couple things. But if you do have loss of strength, loss of feeling, then this defines it as radiculopathy. Whew. So now we go back here. Let's go back to the leg raise. Maybe it was pain-free. You don't have nerve pain. You have what we call referred pain. So just because you feel symptoms all the way down below the level of the knee into the foot doesn't mean that it's due to a nerve problem or that you have sciatica. And we just showed you how to rule in or rule out sciatica. If you don't have a yucky leg raise, then we could be 95% or more sure that you don't have sciatic nerve irritation. Well, what could cause pain all the way down there? Well, it could be that you have a disc which is irritated or a joint which is irritated up in the spine, and it's not affecting the nerve root, but that structure in and of itself can actually send signals down the leg below the level of knee into the foot. Now, I will tell you it's not very common that does happen. Most of the time, if you have referred pain, symptoms are going to stay above the level of the knee, but there are some cases, and I have seen specifically, of irritation of structures up in the back or the hip joint or something like that, and people can feel pain all the way down into the toes. So what are our options? Again, probably not sciatica. Could be a disc problem that's causing referred pain. Could it be a facet joint, degenerative joint, arthritic joint? Could be lumbar spinal stenosis, where again, your brain could be playing tricks on you. So let's figure out how to kind of differentiate between these things. If it is a mechanical problem, you should be able to reproduce it with motion. Let's go through each of these motions one by one. Stand on up, feet shoulder width apart, bend straight backwards. Is it yucky or is it not? And get an idea of how far you can move. Does it shoot pain into your back, butt, or leg? If so, how far can you go before you feel it? If that doesn't bother you, try rotation extension, twisting your trunk all the way to left and bending straight backwards. Is that painful or problematic or no? Number 3, rotation extension to the right. So now go ahead and twist your trunk all the way to the right and bend straight back. And is that yucky or not? And again, you can have a couple possible responses. It's either going to be pain-free or it's going to be painful. Most likely it will be painful. So now what I want you to do, and we'll revisit the pain-free in a second, is I want you to do what we call a repeated motion test, repeated movement exam. So as tolerated, I want you to repeat your yucky back bend, just pick one that was yucky, 10 times. And I want you to get an idea for what happens. So as you're doing these reps, you're going to feel it. And if tolerated, and only if tolerated, keep going. And I want to know what happens with each rep the more you do it. Pain is either going to stay the same or get worse the more you do it. That indicates one thing. Pain is going to lessen the more you do it, or it's going to move around. That's going to mean something else. And if you're not sure, we can help you figure that out as well. Let's just say that pain stays the same. There you are. Ouch, 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 ouch. And or it gets worse. So this is most likely only one of two things. It could be lumbar spinal stenosis, and well, we just repeat the same exact flow chart with this list of symptoms, with this list of findings. We go through a simple self-up-tall test, and we come to some conclusion about what's happening. So revisit the spinal stenosis. You'll be able to see probably some tags in the description here, so you know exactly where you need to go back to that, okay, some timestamps. Or it could be a facet joint problem. So if you irritate a facet joint, it can absolutely cause you to feel pain in your back, butt, and or your leg. But let's just say the more you do it, again, it doesn't get any better. This is what we would classify as an absence of centralization. Centralization being a phenomenon most likely linked to disc problems. And so if you're not seeing your symptoms are moving or getting any better, then could it be a joint problem in your lower spine? The facet joint problems, just so you're clear, this is a facet joint. So this is where the problem occurs between the bones or the vertebrae in your spine. Now, this is the research that we may cite to kind of talk about these additional findings. Age greater than 50 years old. So we talked about disc problems earlier. Age less than 50 years old. So as we get a bit older, a lot of times these joint problems creep up and become more prevalent. Do you have no pain when you're getting up from a seated position? No issues with transition. Remember, disc problems often do. Do you have no issues coughing, sneezing, or straining? Disc issues awfully do. Is your pain better while walking or sitting? It's kind of useless, but that is in the research article there, so I put it. And oftentimes you'll find the yuckiest motion is the one where you're twisted, rotated, and bending backwards to the painful side because you're maximally closing down on these joints in the spine. You can picture these things kind of coming together as you would do that. Now, let's just say that pain lessens the more you do it or moves in location. Then this shifts the probability very much so towards a disc problem. You can see here pretty much everything else is non-existent probability-wise. And likely what you're experiencing, if you're doing the back bends over and over again and your symptoms are getting better, this is likely a sign of what we call centralization, whereby your symptoms may be started in your calf and your foot. And remember I said get an idea of what happens the more you do it. And if it goes from your calf to your foot to just your hamstring, but your calf and your foot is better, and or maybe the leg pain goes completely away and it's just in your back, or maybe it just moves to your butt. This means symptoms are moving closer to the origin of the issue, closer to the spine. This is highly diagnostic of a disc issue. Now, what type of disc issue? Most likely, it is a disc that is intact versus an extruded disc or a sequestrated disc, whereby the disc wall is actually kind of broken and some material is leaking out. If we're able to change the location of symptoms with repeated motions, then it's usually a disc that is intact such that repeated motions can actually move the disc material such that it can change pressure on certain structures and you get less symptoms down the leg. So just something to consider. It's not an exact science there, but as we talked about earlier, here are the signs associated with it. Just go ahead and check the timestamp for a disc issue if you want to review that in more detail. Now, if you're still not sure, you go through doing these motions and you're like, okay, well, I did these repeatedly and I don't really know what happened. Here's something sneaky that you can try on. Go ahead. What I want you to do is I want you to perform your yucky back bend just one time. Then I want you to hold a seated forward bend if possible. If not possible and it's painful, it's fine. Don't do it. But if it's tolerable, hold the seated forward bend for roughly a minute. Then I want you to immediately stand on up and try to bend backwards. And if you notice that you are significantly stiffer and oftentimes more painful, then this points to a disc issue. If there is no change in the motion you experience or pain that you have, this points towards it being more of a facet joint problem. Now, why? If you're bent forward, this generally increases the pressure in the discs. It generally decreases the stress on the joints. And so if bending forward is able to then immediately change how well you're able to bend backwards, then this points to there maybe being a soft tissue, a rapidly changeable tissue in the body that through bending forward becomes stressed out. And then when we go to try to bend backwards, it causes a block of the motion. So if your symptoms and your range of motion are rapidly changeable, then we often say it is a disc problem or it points towards that being the issue. Versus if you're in this position, you're actually relaxing and or taking pressure off the joints. And then when you go to bend back, it's worse for some reason. That would be a little bit odd, more of a joint bony problem. Bony problems aren't going to change this rapidly in 60 seconds. Hopefully that makes sense. Go back and review it if it doesn't. So where did we start? The leg raise was negative. Okay, we've got referred pain, not nerve pain. Disc, facet, lumbar spinal stenosis. Brain, we went down, we did the back bends. If it's a mechanical problem, you should be able to reproduce it. We talked about what would happen in the most likely case or scenario that it's painful. But what if it wasn't painful? What if it was pain-free? Well, maybe we just didn't move your spine in a direction where the disc or the joints were irritated. So let's go through a full exam. I want you to stand and I want you to bend forward, straight forward. Then I want you to go ahead and bend forward to the right, bend forward to the left, side bend directly to the right, side bend directly to the left. If painful and limited any of these motions, then it points towards mostly a disc problem. If all these motions, the entire clock of motions is pain-free, and you can't clearly, consistently reproduce your symptoms, then this points towards it being potentially a more centrally driven issue. Brain. Okay. That's that. So now, here we are. So remember I said, your body can cause you to experience pain due to damage of some structure in the body. But your brain can also make a bit of a mistake whereby the pain you're experiencing is not due to damage, but instead due to perceived danger. Your nervous system is stuck in a state of fight or flight. If you've stuck around this long, thank you so much. You do not have these things, or very unlikely to have these things in the body causing you symptoms. So what could be the most likely cause? Central sensitization, whereby the brain, again, can cause very real physical pain, symptoms, or sensations anywhere in the body, and it can mimic any of these things. It can look like it's spinal stenosis to a T. When I bend forward, my pain goes away. When I stand and walk, it gets worse. When I lift something, when I cough, when I sneeze, my symptoms get worse, but maybe it's not due to a disc issue. I have pain, numbness, tingling, Charlie, right here in my leg, goes all the way down my leg, and I know it's sciatica, but you don't have a positive leg raise. What's going on? Well, how we tease this out is to not try to convince you of anything, because that doesn't work. Instead, just answer these questions. And if you answer a certain amount of yeses, then that indicates more of a brain thing. If you say a certain amount of no's, then potentially a body thing would need to do more evaluation. Okay, so here it is. Are you unsure as to why your pain began? You have no clear injury or cause as to why your pain started. Well, this would be odd. Because if you damage your body, I don't know about you, but I usually know when I hurt myself. So if I whack my finger with a hammer, it hurts now in the moment and it hurts later. So if you're saying my pain just came on and I can't move and I've got stuff going down my leg and I don't know why, there's no reason, then are you sure it's due to damage in the body? So again, you want to answer yes or no. Are you unsure as to why your pain began? Yes or no? And it should be clear, by the way. It shouldn't be like, I think because I started to work out more, or I think because I started to do this or that. It either happened or it didn't happen. Is your pain chronic, greater than 3 to 6 months? Most disc issues, most problems in the body will heal within roughly a 6-ish month time frame. So if your pain and symptoms are present for more than 3 to 6 months, you have to start to say, that's weird. Why wouldn't my body have healed it? Could it be that your brain has learned it? So yes or no. Did your pain begin during and or around a time of fight or flight, good or bad? Birth, death, financial strain, new career, relationship stuff? Did it begin around one of those times? Is your pain inconsistent? You have some good days, bad days, but you don't know why. Sometimes you can sit, sometimes you can't sit. This is weird. This is a sign of it being centrally driven. So yes or no. Does stress trigger a pain? Yes or no. Do you experience relief of your pain with distraction? If you go on vacation, do you all of a sudden feel better? On the weekends, do you feel better? On Monday, you feel worse. If you're playing video games, you're talking to your girlfriends or your boyfriends or your guy friends, whatever you call them, do you feel better? And you can't explain it. If so, that is a sign. Do you have pain, symptoms, or problems elsewhere in your body? Migraines, GI issues, shoulder pain, knee pain, neck pain, and you don't know why. Nobody can figure it out. What are the chances you have all those individual problems wrong with you? Not very high. What are the chances that one thing is driving it all? Much higher. Could it be the brain? Do you experience a delayed onset of pain? Do you do something today, but then tomorrow you pay for it? I felt fine when I was gardening. I felt fine when I was lifting, but then later that day or tomorrow, I feel worse. That doesn't really make sense if you have a structural cause of your pain. When was the last time you hit your finger with a hammer and you didn't feel pain while you hit it, but then later it hurt? That wouldn't make sense. You would feel it now and later. So if it's just a later and you forgot the now, then that is a symptom of the mind. Have you been given many or no clear diagnoses? Probably because nobody can agree upon what's happening. Maybe even your x-ray or MRI is clear and they're just kind of like giving you random reasons for why you hurt because, well, you're asking for them. Then this is a sign that maybe people can't agree upon what's happening because there's actually nothing wrong. Do you identify yourself as having a high pressure, perfectionist, people pleaser, type A? Charlie, just tell me what to do and I'll do it all darn day. Folks like this tend to live in a more elevated state, a higher state of fight or flight, which sort of predisposes the nervous system to getting stuck in this on mode. Bells and whistles are constantly going off. Is it hard to identify clear yuck emotions that consistently reproduce your pain? We touched on this earlier. If you go through a movement exam and you can't clearly reproduce your pain, Andrew, one time this hurts, the next time it doesn't hurt. My leg raise hurt today, but tomorrow it doesn't hurt, and then at morning it hurts, and then at night it hurts. That's not consistent. You would say, yeah, it is hard to identify clear, consistent patterns. Has there been a lack of response to physical treatment? If yes, well, maybe it's not a physical problem. All right, so I wanted to explain those a little bit just to give you some context. If you answered yes to 7 or more of these 13 questions, then chances are very high that it's more driven centrally, and we need to focus on treating the central nervous system, not necessarily the body. If you answered yes to 6 or less of these 13 questions, then it's possible we just need to go more into diagnostic mode. We need to go more into the orthopedic side of things and start testing things and teasing things out further to figure out what the heck is going on. So there you have it. There's the complete diagnostic flowchart. This is exactly what goes through my head from the second somebody calls me and says, I have a pain in my back and my butt and my leg. And of course, everyone just asks, well, what could it be? It's like, well, where do you want to start? And do you have an hour to work through it? And so this is why I work with people all around the world to help you figure out the most likely cause of what's going on, so you don't have to try to DIY it or figure it out on your own. That being said, if you're interested in learning how to solve this problem and you want more information on how to fix these issues that I talked about today, just check out my other videos on this topic so you can learn to solve these problems naturally. Thanks so much. Let me know below too in the comments, was this helpful or was it not? Thanks.